Yes. It is broadcast now through YouTube. It says.
I've got the same message.
Yes, maybe you should go full screen, Bullet.
All right. Good afternoon, everybody. This is the meeting of Association for Community Mental Health promotion with world's leading educators. It's our fourth meeting. I will try to go through it. Today's topic is, what does being a doctor mean? In the June meeting of this, we will be discussing being a doctor with two distinguished medical educators. Professor Driss Moussaï from Morocco will be presenting about ingredients of a successful professional life in medicine. We will learn a lot from him. And Professor Bill Fulford from the United Kingdom will talk on a very brief introduction to values-based practice and shared decision-making in medicine. We have three discussants, one Pelin Özkara Menekşeoğlu, the other İrem Keçeci, and Onur Çağın Gürlek. I'll come to them in a few minutes. Driss Moussaï is a professor emeritus, Faculty of Medicine, Casablanca, Morocco. I'm sure he will say a few words about mysterious Casablanca. In very brief, he was the founder and chairman of the Ibn Rushd University Psychiatry Center in Casablanca from 1979 to 2013. He was also director of the Casablanca WHO World Health Organization Collaborating Center in Mental Health from 1992 to 2013. He was president of the Moroccan Society of Psychiatry and of the Arab Federation of Psychiatrists. He edited or co-edited 10 books and published more than 150 papers in international journals. He is past president of the World Association of Social Psychiatry and member of the French Academy of Medicine. He is WPA, World Psychiatric Association, and World Association for Social Psychiatry honorary member, and currently president of the International Federation for Psychotherapy. He is such an international colleague. He founded with the World Psychiatric Association Executive Committee the John DeLay Prize in 1999, and in the scientific director of the WPA series, International Anthologies of Classic Psychiatric Texts. We don't have any Turkish there. We have French, German, Spanish, Italian, Greek, and Russian is in preparation. Maybe one day, Turkish may be added. And our second distinguished friend, colleague is Professor Dr. Bill Fulford, a fellow of St. Catherine's College and member of the philosophy faculty, University of Oxford. He is emeritus professor of philosophy and mental health at University of Warwick Medical School, founder director of the Collaborating Center for Values-Based Practice, St. Catherine's College, Oxford. I would suggest our audience to go and visit this webpage. I'm sure they will. His previous posts include honorary consultant psychiatrist at University of Oxford and special advisor for values-based practice in the Department of Health. His publications include, of course, not limited with these, Moral Theory and Medical Practice, the Oxford Textbook of Philosophy and Psychiatry, and the Oxford Handbook of Philosophy and Psychiatry. He is lead editor for the Oxford book series, International Perspective in Philosophy and Psychiatry, and founder editor and chair of the advisory board of the international journal Philosophy, Psychiatry, and Psychology, 3P. His Essential Values-Based Practice, co-authored with Ed Peel, is the launch volume for a book series that he edits for Cambridge University Press on values-based medicine. These two brief information are really brief about our dear guests. The three discussants, Pelin Özkara, İrem Keçeci, and Onur Çağın Gürlek. Let me try to introduce them. Dr. Pelin Özkara Menekşeoğlu is a fourth-year resident at Bakırköy Mazhar Osman Mental Health and Neurological Diseases Education and Research Hospital in Istanbul, a long name. And maybe Dries may have heard about Mazhar Osman. He is a pioneer in Turkish psychiatry. I don't know, maybe Bill also. And İrem Keçeci, last year medical student at Marmara University School of Medicine, Istanbul. We call our last year students interns, but in other places in the US, they say for the first year of the residency period, I understand. Oh, I'm lost. I'm lost. Sorry. I will be coming. And the other last year medical student is at Hacettepe University Medical School. And he is also a PhD student at the Institute of Neurological Sciences and Psychiatry of Hacettepe University, Ankara. And me, chair of Association for Community Mental Health Promotion. And I'm a retired faculty member of Kocaeli University Psychiatry Department. Now, this is finished. And I'm stopping. I will try to stop sharing if I can. I hope I can. I have problem in stopping. Yeah, I did. Well, it has been a long introduction maybe. May we start with Dries Usay, please. The floor is yours, sir.
No, it's not that. It's interesting that I will do my best to find a way.
I know why you are doing this. You are just.
We did it a few minutes ago.
And no, you know, I have messed things up, and you say I'm not the only one doing that. I know how kind you are.
Okay. Okay. Oh yes, no, it's. I know why it didn't happen.
Here it is.
Is it?
Yes.
Yep.
Excellent. Excellent. Let's now put it full screen.
Please.
Okay. I just wanted to say a few words. I will not be long about self-evident things you know about already, but it is so extremely important to remind you that. Self-evident things have to be said and said again. Very, very important. But we'll discuss. I mean, it may have some click something on your mind that might be of importance. So first, there is no professional success without personal good life. Impossible. having said that, I could stop here because this is the main message, in fact. And very simple. If you are not happy, if you're not well, you will not be able to help people who are not well. You cannot have a fever and feel weak and go to the sea, seeing somebody drowning, and go to help this person. It's impossible. You have to be fit, you have to be well in order to help the others. You cannot be well if your family and your beloved ones and your friends are not well. It impacts on you. If your brothers and sisters, father, mother, whatever, in the morning say terrible things to you before you go to the hospital, then you will not be in the best shape to help those in need of your help. Social life is extremely important. We have seen through this pandemic that people are miserable when they are locked down. And that without going out, culture, traveling, doing sport, having interaction in civil society, then forget about it. You're not in good shape. Still, you will never be all the time in good shape. You will never be happy all the time. It's impossible. You will have ups, you will have downs. You will need to deal with them in the best possible way. When you're up, it's okay, but don't forget, after ups, you have downs. إن بعد اليسر عسرا. But after downs, you have always ups, or almost.
Excuse me, what was that?
إن بعد العسر يسرا is a sentence from the Quran. After difficulty, you have always good moments. Okay. And after good moments, you have always difficulties. That's the cycle, day and night, always. That's the law of life. So try to minimize the moments you are down and make it in the best possible way working when you are in good shape. So medicine is an extraordinary profession. It's there are mostly the two oldest professions are first medicine and second prostitution. But medicine is even older. People have always tried through all kinds of things like herbal medicines and prayers and things and this and that to improve the health of suffering people. Medical field is huge. It's an ocean. It's we can take the metaphor of a palace with a huge number of rooms, and it's expanding year after year. There is no medical specialty that is not bio-psycho-social in interaction practice and theory as well. There is no illness where you don't find necessarily biological aspects, psychological aspects, social aspects. Doesn't exist. And in this ocean or palace, I would say, you need to find the best place. And to know, to choose the room that fits you more or better or best. Because you have more windows, more light, to have better walls and high ceilings. And what is of interest to you? I never thought I would become a medical doctor. What was of interest to me was human sciences. But I found that psychiatry was the nearest to what was of interest to me. So choose the field that you like and that could be consonant with the medical field. You like mathematics? Go for statistics. You like informatics? Go for medical informatics. You like, I mean, I have a brother who is a professor of gyneco-obstetrics. When he was a child, he used to completely open up what's inside the TV set and to put it again functioning. he liked that, and he liked to be a surgeon. Main question is, and will be throughout your professional life, how best can I help ill people? This is something, because this is what we are. We are there to help people in need of help. Ingredients of success: first is knowledge. Be a good technician. Know as much as you can. Technically, but you should know also that knowledge changes all the time. And what you have learned today in 6 months might be completely nonsense. So you need to learn all the time in your professional life. But also wisdom, professional wisdom. I mean, I know people who are extremely knowledgeable in medicine, but who are terrible clinicians and therapists. I mean, it's not because you know something cortically, cognitively, that you are going to use it in the best possible way. And there you have to be creative. It's an art as well. You have to be creative. You have to be to give the best knowledge at that moment that can be different from other moments. Humanism. It goes to a simple question. Do you like your patients? Do they like you? If you don't, change your profession. If they don't like you, you should ask yourself, there is something wrong with me. What is it? Of course, you cannot be liked by everybody, and you cannot like all patients. It's impossible. But if it happens with 80 or 90% of all patients, that's okay. That's good. And networking is so extremely important. Aristotle said, we are social animals. This is true. And when you see the very first book on suicide written by a non-medical doctor, and non-psychologist, it didn't exist at that time, almost, saying how anomie is terrible and how social bonds, when they are destroyed mentally, the people, and you have more depression and more suicide. So you should create and maintain the best possible links, ties, bridges, connections, bonds, and so on and so on, with mutual interest. Creativity is very important. If you are doing like a robot, the same thing all the day long, all the year long, you will be fed up, and you will leave, or you will be depressed. You have to be, did I do well with this patient, with what I know? Until things are really satisfactory, they are not. So you should try and try and try again. A lot of work, always. We have, there is a saying in French, 20% d'inspiration et 80% de transpiration. So it sounds good. Well, it's 20% inspiration and 80% sweating. You know, we are all about the same, I would say, IQ, or, you know. And the difference is with those who work versus those who do not work enough. If you want to be successful, you have to work a lot. But again, networking, choose to work with the best people whenever possible. I know it's not easy, because you have sometimes, you know, terrible people who would like to work with you. Yeah, you can give them some time, some effort, some energy, but try to work with the best, connected to these good people, and keep an eye on international scene through publications and congresses. You might suffocate in your city, in your country. Go abroad, go to congresses, see other people, talk to them, and this will be oxygen to your mind, and you will progress like that. But again, first commandment is be well as much as you can. Healthy lifestyle, sleep well, very important, even more than eating. I remember when I was the first and only psychiatrist in the public sector in 1979 in Casablanca for four cities and 5 million inhabitants. It happened to me to see 72 mental patients in one afternoon, and to be so exhausted when I came back home, I couldn't eat. I just fell on my bed and slept until 7 a.m. to go back again to the battle. Very important, the sleep. And what I did is, you know, to see them. Hello, how are you? Did you take your medication? Yes, very good. Continue, very important. And most of them were psychotic people. Renew the prescription, because otherwise, if they stop their medication, 2 weeks after, I see them in the department where I had only 50 beds for 5 million inhabitants. And I received 50 patients a day to be hospitalized. So sleep, eat, and exercise. I shouldn't say something but I'm going to say it. This morning on the beach, I'm 200, 300 meters from the beach on the Atlantic Ocean. I run 7 kilometers. I'm 72. Never think that you're too old to exercise. Never. And when you exercise physically, it helps mentally as well. All addictions are detrimental. And if you feel that you are not well, please ask for help. It's not a shame. It's not, do it. There is a professional cycle. As a student, find the best helpers among teachers. Not all teachers are that excellent. As a medical doctor, find the best colleagues and collaborators to be a successful team. If the team is successful, you are successful. If not, can't be. As a teacher, afterwards, one way or another, find the best students to whom you will convey the message and give them the best teaching. To conclude, we MDs are the servants, sorry, there is an S missing, of patients and of one good cause, health. We teachers, when you are and you become teacher, we are the servants of the students. You know, when I teach students, I tell them this, you are the servants of the patients. Why does he say that? Say, you know, I'm your servant. Want to know if I'm saying the truth? Very simple to test. If you come to my office, and I have trained in Morocco more than 12,000 medical doctors. Say, if you come to my office and there is nobody in my office and you stay outside in the corridor more than 5 minutes, then you can say, Driss Moussaoui is a liar. And I won't believe what he says. I'm your servant. Do not forget the extreme importance of prevention and promotion of health for society. I mean, 2/3 of what we treat in the world could be prevented. And if people are healthy, they are not ill. And our goal is not to treat ill people, but also to make them stay in good health and fit. No person is an island, and no medical doctor is an island. We are nothing without our team. Just to tell you one story. You know how I learned about rabies? In 1979 or 1980, it was the man, illiterate, who was cleaning the floor in the department, who told me, because there was a patient who was extremely agitated. Hey, doctor, this man has been bit by a dog. Goodness, please bring a glass of water. When he saw the water from far, he became even more agitated. So the diagnosis of rabies was made by this illiterate man who taught me how to diagnose a case of rabies. We are nothing without a team. And every single person is important without a network. And of course, our best teachers are the patients and their families. And we learn a lot of them. Please listen to them and you will learn. Finally, think of being in the best of your health and your family as well. again and again. Your first patient, I would say, between brackets, is yourself and your beloved ones. Thank you for your attention. 20 minutes, Bulent?
Exactly. Great. Thank you very much. Maybe, yeah, you could stop sharing and we can all see each other. Yes, excellent. Thank you very much. You have shared your wisdom with us. And the first advice was being happy. You told us to be happy. I hope we can. May I ask my young friends, would you like to have some questions, remarks about what our professor told us? Please, Pelin.
Hello. First of all, I would like to thank Professor Musai for your inspirational presentation. It made me think about the difficulties in our professional life, like stigmatization of psychiatric conditions. So what was the biggest challenge you faced in the past on your way to becoming a successful psychiatrist? What would you recommend us to overcome these difficulties?
I will tell you if I was a successful psychiatrist 10 minutes before I die. Not finished. This is one thing. I find difficulties, problems, challenges every single day that I have to overcome. And they are numerous and sometimes completely unexpected. So, I mean, all kinds of things. The patient who tells you, you know, your treatment is rubbish, doesn't help. Okay, what went wrong with him or with her? And try to think when administration. I mean, we were going to build the very first in the country, the very first center for phase 1 clinical trials. And we had such a terrible mess around that. We didn't expect that. I can give you thousands of examples. I mean, with administration, with patients, with I mean, the day you have very small number of challenges is how can I say, is a blessed day. Just thanks God, it went okay, day after day.
Thank you very much. I think that would be it's the best answer you could give. Since we are still living, it's not finished.
Never.
Never. All right. What about İrem or Onur? Would you like to say anything or any comments or any questions?
I have a question also. First, I also would like to thank you for your presentation. My question is, just like you said, humanism is a very important aspect of our jobs. But a lot of providers, due to numerous reasons, feel like they have burnt out and they feel like they have lost the empathy that drove them to medicine. How can a medical professional can regain their humanistic approach and empathy after feeling like this?
You know, when you don't feel well, go to people who can help you. That can be your friends, can be your family. Talk to them. Maybe your way of life is terrible. I mean, if you work 18 hours a day, then, I mean, you will collapse. I used to work when I started 14, 15 hours a day, but that was crazy. I told you about the 72 patients. I mean, nonsense. Now, I mean, I watched a small video of the founder of Apple, Steve Jobs, who said you have two ingredients of success: a huge amount of work and choosing the best possible collaborators. This is what he said. And he said, believing in what you do, whatever the others say. They say you're crazy. Okay, I'm crazy. Let's do it. You know this sentence, we didn't know it was impossible to do, so we did it. When I started being the chairman in 1979, I was 29 and a half, something like that. And I would have never thought that we would do the team all together what we did. Never. But it didn't. Many people didn't like it. Why do you do so many things? I mean, what do you mean that we are stupid and we don't do and things like that? It reminds you of something. Probably because if you work too much, do you want my seat? Do you want my position? What is this? But just do it. And be as much diplomatic as you can.
Thank you so much.
Many thanks. Yeah, it's İrem's turn. What are you going to say, İrem?
So first of all, thank you for your great presentation. I think that having role models is so important in the field of both medicine and psychiatry. And because of that, I think the meetings like that are so beneficial for us. And thank you again. I have already noted some sentences that you said because they were just like slogans for me. And I also have a question. It's a bit related to Onur's question, but I will ask it. So as medical students, we also experience psychiatric problems from time to time. And we talked about happiness is so important for our success, in our personal professional lives. And I don't think that as medical students, if we know where to consult when we have psychiatric problems. And do you any advice what we can organize in our faculties, maybe together with psychiatry departments for students for their mental problems? Thank you.
What you say is very important. Just to reassure you, there is nobody on earth who does not go through a difficult moment from the mental point of view. You know, WHO, that is extremely conservative, says 1 out of 4 people in the world will have a mental disorder in one's life. Other, in the US, in the United States of America, it's 52%. But my feeling is that, in fact, a huge number of people, almost 100% of people will one day or another have an anxiety disorder, depression, can be short, but it's there. Who can say that he or she has never been physically ill during 1 year or 2 years, having a flu, having something, I mean, a bad knee or whatever. Nobody can say that. Why would it be different for psychiatry? Having possibility of helping medical students in departments of psychiatry, very important, should be implemented, but medical students must know that they can be helped and accept to be helped. And those working in the Department of Psychiatry should be friendly to them and be helpful. That's all I can say.
Many thanks again. We are receiving notes from some of our audience. One friend, Gürkan Doğan, says, "Thank you so much for sharing your invaluable experience and wisdom." Aybi Keşan says, "Thanks for the amazing presentation." We do not have too many, crowded number of people following, but I think they will benefit after they watch. Now, I have some other things to ask, but I would prefer to ask them together to both of you later. May we turn to Bill? Would you like to share your presentation?
I will try.
Please.
So are you seeing my slides now?
Yeah, yes.
Wonderful.
Great.
So thank you very much, Bulent, for inviting me to take part in this very inspiring session. I'm, as you know, going to present something rather different from Driss's inspiring account of what is required to be a doctor. You see, I've called it a very brief introduction to values-based practice and shared decision-making in medicine. I'm not going to be quite as brief as Driss, but I'm going to cover a fair amount of material. There is an important link, I think, with Driss's excellent presentation. Driss, one of the things that you recommended was that we ask ourselves, how best can I help ill people? How best can I help ill people? What my presentation is about is understanding that what is best for one person will be sometimes very different from what is best for another person. Now, you may think that is obvious, but we as doctors tend to approach our patients thinking that we can help them, which of course our training encourages us to do. And we're inclined to think that perhaps we know what is best for them. But the whole point of working in values-based practice is to come to understand that it is often very difficult to guess what is best for a particular patient. I'm going to give you some examples in a moment, and that we really need to develop our skills for working with values as well as our scientific skills for working with evidence. And that will lead us to this model of shared decision-making, which is becoming more and more important in all areas of medicine, including, of course, psychiatry. So I'm going to cover 4 topics. I'll start with a general introduction to values-based clinical care, and there I'll be telling you the story of Mrs. Jones's knee. Both of the clinical stories I'm presenting are based on real people, but of course with biographical details changed. We'll then move to the extra challenges of mental health care with the story of Anna, and I'll then be running through some of the resources from philosophy and phenomenology that can support us in meeting the extra challenges of values-based practice in mental health care. And finally, I'll draw some conclusions and indicate some of the resources that are available for further study. Bulent, I think you kindly pointed our colleagues to the website of the Collaborating Centre. I'll give the address again at the end, but all the resources I'm talking about are available through that website. I've included two what I've called question and answer sessions after the first two parts of my talk, but given the way that the meeting is running, I'm wondering if it would be better to leave all the questions and answers to the end, and then maybe our colleagues could, if they have any questions, could pick them up at the end rather than as we go through. Would that be acceptable? I'm getting a nod.
Of course, of course.
Very good, okay. So let's start with values-based clinical care. Now, the first thing I'd like to say is that we have many different ways of working with values in medicine. I'm sure as medical students, you'll all have done a lot on medical ethics, and this was sitting behind many of the things that you mentioned today about the importance of ethics in our profession. Medical law, of course, is a second area. I'll give you an example of this in a moment. And then we have more elaborate technical ways of working with values, decision analysis, which is used in providing support aids for making clinical decisions, and health economics, which helps us to manage the cost of healthcare. So values-based practice fits in a toolkit. It's not to be considered on its own. And what values-based practice brings is an approach, a process that I'll describe in a moment, that is aimed to support balanced decision-making where our values are diverse. And remember, I said this is about what is best for one patient may be different from what is best for another patient. It's that diversity that we're engaging with. The other thing that I'd like to say at this point is that I'm using the term values in a very wide sense. Where we do training in values-based practice, we start with understanding about the diversity of values, and we get to this definition that values, as I'm using it in this context of the skills we need for values-based practice, values is about anything that matters or is important to the individuals concerned. Anything that matters or is important to the individuals concerned. And again, I recall that, Dris, you talked about thinking as a medical student, what is the most interesting part of medicine for me? That's part of our diversity as individuals, our own values as doctors and students. What is of most interest to me? This is very close to the idea, it's what is of value, what is matters, what is important to me. So values in that broad sense, individually highly diverse. And it's that broad sense of values that makes it part of the basis of shared clinical decision-making, as I'll describe in a moment. So this is the process of values-based practice. As you can see, there's a process that doesn't give us an answer, but it gives us a way of coming to an answer for ourselves, and in order to make balanced decision-making on values, and that's the basis of this model of shared clinical decision-making. Now notice that I've highlighted the letter V there as standing for values-based practice, and that's because values-based practice is, in this respect, very like evidence-based practice. You see, the only thing I've changed there is the V to an E. And evidence-based practice is also a process that leads to balanced decision-making where we have diverse evidence. And as you'll see, that's also the other basis of shared clinical decision-making. So we have, and we'll see how this works with a clinical example in a moment, we have evidence-based practice and we have values-based practice. As if I'm holding up my two hands, it's like the two hands or the two eyes or the 2 feet of shared clinical decision-making. This is the process of values-based practice in a bit more detail. And again, you'll find all this on the values-based practice website, but you'll see that there are actually 10 key process elements of values-based practice. In evidence-based practice, we have meta-analyses, randomized controlled trials, other elements of the process of working well with evidence. The process of working well with values starts from developing our clinical skills. You'll see there are 4 clinical skills at the top there. And of those 4 clinical skills, the most important is simply raising awareness of values and of the diversity of values as they impact on clinical care. Much of the training that we do in values-based practice is all focused on that first area of clinical skill. And again, you'll find lots of examples on the website if you want to pursue this. But as well as clinical skills, we have to have the right model of service delivery. Dris, you mentioned the importance of networking and teams. But teamwork is crucial to values-based practice as the basis of what is widely called person-centered or patient-centered clinical care. These are the 2 key aspects of the model. There are then 3 specific and very strong links between values-based practice and evidence-based practice. I won't go through these in detail, but there are substantive links between the 2 approaches as well as a surface appearance. And finally, a model of partnership in decision-making. Technically, it's called dissensus, and dissensus is a bit like consensus, but whereas with consensus, everybody comes to the same conclusion, evidence-based practice is based on consensus. With dissensus, there's room for people to come to different conclusions, which may be balanced according to the circumstances of a particular case. This is called technically in value theory particularism. And of course, like any area of philosophical theory, it's open to a lot of critique and discussion. But for good or ill, that is what this approach is based on, dissensus as a form of moral or ethical particularism. So here is the model, again, of partnership, value practice, working alongside evidence-based practice. Evidence-based practice gives us the science. Values-based practice allows us to link that science up with the diversity of values of our individual patients and their families in this model of shared clinical decision-making. So how does this work out in practice? Well, I've mentioned several times our website. This is a picture of the Collaborating Center for Values-Based Practice, and the website is there, valuesbasedpractice.org. Dris will recognize that I'm being a bit unfair here because this is actually a picture of St. Catherine's College. I'm afraid our centre is, like most Oxford activities, almost completely without funds, and it exists as a virtual centre, but we do have the wonderful advantage of working within this very beautiful college in Oxford. As you can see, it's a relatively modern college, but it has the traditions of an Oxford college, but set in the context of a 1960s Scandinavian building, which is extremely comfortable and a very nice place to work. So Dris, if you could perhaps have added find the right place to work into your list of your recipe for having a happy professional life. So here's a story, and I've called this Mrs. Jones's knee. As I said, it's a true story, but of course the patient wasn't called Mrs. Jones. And it's a story about how values-based practice and evidence-based practice come together in clinical care. So Mrs. Jones was a lady in her late middle age who was referred to an orthopedic surgeon in Oxford because she had a painful arthritic knee, and the referral was to assess her for having knee replacement surgery. Notice that this is not an unusual case, it's an everyday case. Notice that it's a medical case and not, in this instance, a psychiatric case. Now, the surgical team assessed Mrs. Jones, and they found that indeed she had advanced arthritis and she was otherwise very fit and was suitable for an operation. So the surgeon called Mrs. Jones into his study and said to her, well, Mrs. Jones, I'm pleased to say we are able to do this operation for you. I happen to have a slot in my operating list in about a month. It's a fairly major operation, but very routine nowadays. You will need about 18 months physiotherapy, but at the end of that time, so in about 2 years' time, I can more or less guarantee that you will have a pain-free knee. Mrs. Jones looked pleased with this news, and she got up to leave. And as she got to the door, she turned to the surgeon and said, Thank you, doctor. I'm so pleased I will be able to garden again. Now, I just want to pause there for a moment. We're not, of course, doing this interactively, but just think about that. Why would Mrs. Jones make that comment? And why did the surgeon, instead of saying, yes, yes, goodbye, said, come and tell me more about that? Why is this significant? I'm so pleased I will be able to garden again. Well, I guess some of you will have realized that what the surgeon had in mind was that although artificial joints, artificial knee joints are very good at curing the pain of arthritis, they're not very good at giving you back your mobility. And so the surgeon said to Mrs. Jones, come and sit down. And he explained to her this. And he said, if you want to garden, I assume you mean that you need to be able to kneel down and do your weeding and so on. And she said, yes, my problem, of course, is it's not very nice to have a painful knee, but my problem is that it's too painful for me to garden. And the garden is it's the only thing that really matters to me in my life. See, the gardening was Mrs. Jones's values. Most people with arthritis of the knee, what matters to them, what is important to them, is to get rid of the pain. I don't know if any of you have had arthritis of a major joint, but I'm fortunate I haven't personally, but I know people who have, and I can tell you that it's a very painful and very upsetting condition which comes to dominate your life. So for most people, a knee replacement surgery is exactly what they want. But for Mrs. Jones, it was more important that she could garden again than that she got rid of the pain. So they discussed it a bit more, and the end of it was that they decided to go for what's called conservative management. So instead of an operation, they decided to have a period of physiotherapy, not on the knee itself, but on the thigh muscles to build up the strength of the muscles around her knee, and anti-inflammatory medication. So they decided to try that. And the end result was that after about 18 months, Mrs. Jones had sufficient mobility restored to be able to do her gardening. And she was very pleased and reported back to the surgeon that she was now happy and didn't need to have a knee replacement surgery after all. So notice what's going on here. First of all, values-based practice. Remember I said finding out about people's values is the first clinical skill of values-based practice. Now, this surgeon had not trained in values-based practice, but he was what we would call in English a listening doctor. He listened to his patients. And when he heard what Mrs. Jones talk about gardening, he realized as a surgeon that he needed to go into this a bit more because it was what obviously mattered to Mrs. Jones. Now, he realized that as a surgeon, which meant that he brought together with his attention to Mrs. Jones's values, his knowledge of the science. It was the surgeon knowing about the joint replacement surgery, knowing the alternatives to that, the conservative management, that allowed him to connect with what was important or mattered to Mrs. Jones. This was a shared decision between Mrs. Jones and the surgeon, and the result was an improved clinical outcome because, of course, Mrs. Jones was now happy, whereas if she'd had the operation and still not been able to garden, she would have been very unhappy. A much better patient experience because instead of an operation and 18 months physiotherapy, she was able to go straight to conservative management with anti-inflammatory drugs and a different kind of physiotherapy. Of course, there were huge savings of costs for the health service in the UK. An operation like this with physiotherapy to follow costs about $15,000 US or £12,000, and everybody was happy. So this is an example of evidence-based practice and values-based practice working together in partnership in a shared decision-making model out of which everybody wins. This approach, I don't know what the arrangements are in Turkey and other parts of the world, but in the UK, we've had a recent decision, this is 2015, so fairly recent still, in our Supreme Court, which has made that model of shared decision-making based on evidence and values the basis of consent to treatment. You can see why it's important from Mrs. Jones's story. This is called the Montgomery judgment. Again, you can get it through our website if you want to look at it in detail. It is a UK judgment, but it's based in part on international human rights law. And I think this approach is becoming adopted in many other countries and increasingly will be the norm for consent to treatment in medicine around the world. Correspondingly, it's been incorporated into professional guidance in the UK. This is our General Medical Council, which sets the rules for all areas of medical treatment in the UK. And you can see this is their document on consent to treatment. It is actually called Patients and Doctors Making Decisions Together. So shared decision-making based on evidence and values. Now, as I said, I was going to stop here and see if there were any questions, but as we have 3 discussants rather than a general audience, if I may, I'll press on to the challenges of psychiatry. Are you happy with that, our discussants? Good. So let's go on to values-based mental health care. And as you see, I'm going to talk here about Anna. Again, I've disguised her story, but she's essentially a young woman with anorexia. And I've published this story with our colleague Giovanni Stangolini in Giovanni's Oxford Handbook of Phenomenological Psychopathology. And this is Giovanni Stangolini. And I'd like to acknowledge my thanks to him for this story. Giovanni is a very skilled and experienced psychiatrist and phenomenologist, and he's really done all the important work on anorexia and related feeding and eating disorders. And I'll come back to his work in a moment. So Anna's story is typical of young women with anorexia. And in fact, she satisfies what are called the DSM criteria for anorexia nervosa. The DSM, I'm not sure how many of our audience have done their psychiatry attachment. The DSM is the Diagnostic and Statistical Manual, which is the manual of the American Psychiatric Association. And although it's the American manual, and there is a WHO manual, in practice, the DSM is the one that is most widely used. And the DSM suggests 3 criteria for anorexia nervosa, and Anna showed all of them: a significantly low body weight for her age due to restriction of energy intake, that essentially she's not eating properly, an intense fear of gaining weight or of becoming fat, and then criterion C, disturbance in the way she experiences her body, weight, or shape, undue influence of body, weight, or shape on self-evaluation, or persistent lack of recognition of the seriousness of her current low body weight. I've read that last one in detail for a reason that we'll come to in a moment. So Anna shows criterion A and B, and notice that these also cover other non-medical conditions like voluntary starvation, fasting, and the way that athletes and models often train. So it's criterion C, that 3rd criterion, that is critical to the diagnosis of anorexia nervosa. And here is criterion C with certain words highlighted in red. And notice that these are the value words that come up in criterion C. Disturbance in the way she experiences her body, weight, or shape, undue influence of body, weight, or shape on self-evaluation, and persistent lack of recognition of the seriousness of her current low body weight. Now, if we were doing this interactively, I'd ask you for your views on whether I've highlighted the correct values or the correct value words, but I hope you'll take that as being a reasonable shot at the way values are coming into this American Psychiatric Association diagnostic manual. And it's absolutely at the heart of the diagnosis of anorexia as distinct from these other conditions. But now let's look again at criterion C, and then we will see something important, that the values in criterion C aren't those of Anna, they are our values. So when we say there's a disturbance, this is contrasting our values with Anna values. Our values are that there is a disturbance in the way Anna experiences her body, weight, or shape, that there is undue influence of body, weight, or shape on self-evaluation, or persistent lack of recognition of the seriousness of her current low body weight. Now, in the bottom half of this slide, I've repeated those phrases with Anna's values. The way Anna experienced her body weight or shape is not disturbed. As far as she's concerned, it's appropriate. And as far as Anna's concerned, the influence of her body weight or shape on her self-evaluation is not undue. In fact, she evaluated herself very poorly, but that was because she felt that her body weight or shape wasn't adequate. And she thought it was entirely appropriate that she should feel bad about her body weight or shape. And in fact, as she got her body weight lower and lower, far from thinking that this was a matter of a serious threat to her health and possibly life, she regarded it as a positive success or an achievement. Tris, I know you will have seen many people with this condition, and our colleagues training, if you've done any psychiatry and met someone with anorexia nervosa, you'll recognize how we see this remarkable contrast between the patient's self-evaluation and our evaluation. And this brings us to a key difference between Mrs. Jones and her arthritic knee and Anna, which I've indicated here. Remember, with Mrs. Jones, most people with arthritis of the knee, it's the pain they're worried about. Mrs. Jones was different. She was worried about mobility. But when we understood about her interest in gardening and how important gardening was to her, we could completely understand why she was more worried about mobility than pain. With Anna, I think it would be fair to say that for most of us, her values are not only different, but we can't immediately understand them. It seems extraordinary that Anna should feel that she's starving herself almost to death, and she sees this as an achievement, not as a threat. Why? Well, we'll come to why in a moment, but you see how immediately challenging this is to coming to a balance of decision, a balance of values as the basis of shared clinical decision making. At first glance, there's no balance to be struck here. Anna thinks one thing, we think another, and unless we're prepared to let her essentially starve herself to death, there's no balance to draw. So again, I was going to stop for a Q&A here. I hope I'm not going on too fast for our colleagues, but I can take the story a little further, if I may, with the philosophy resources for addressing this challenge, and then we'll come through the resources to a final Q&A. Okay? So philosophy, phenomenology, and values-based mental health care. Remember, what we've got to is that Anna's values are challenging for values-based practice. It's the same model that we could apply to Mrs. Jones's knee, but Anna's values are challenging because we can't immediately understand. They are different, as were Mrs. Jones's values, but they're different and they're very obscure. We don't understand how can anybody adopt these values. Well, this is where philosophy can start to help us. And I'm going to suggest to you, it's not my own area of philosophy, analytic philosophy, so much as phenomenology, the work that Giovanni Stangalini and others have been doing. But to start with where values-based practice started, values-based practice came from work in what is called ordinary language analytic philosophy. Of course, I won't be going through this in detail, but the key about analytic ordinary language philosophy is that it starts naturally with case studies, and it involves looking carefully at language use. You can see, I think, how we've been doing ordinary language philosophy in a way. When we looked at Anna's story, we were struck by the difference between our values and Anna's values, and we got to that difference not by a sort of external critique of the DSM or by thinking about Anna's story in some philosophical way. We got to it by looking very carefully at the criteria for anorexia nervosa in the American Psychiatric Association Diagnostic and Statistical Manual. So it's the language of psychiatry that shows us the values in Anna's story and brings out this key challenge that her values are both different and not immediately understandable. So that's what analytic philosophy can do for us. But how then can we understand Anna's values? And this is where phenomenology comes in. And this is where we come back to Giovanni Stangolini's work. And Giovanni has extensive experience of not only anorexia, but other feeding and eating disorders. And he's analyzed these disorders using the work of a very famous 20th century phenomenologist, Jean-Paul Sartre, who developed a three-part or three-way phenomenology of the body. Now, phenomenology is about understanding subjective experience, and this is a way of understanding our subjective experience of our body. I won't go into the three-part phenomenology in detail, but essentially what Giovanni Stangolini has done is to show that we can understand the values of someone like Anna by looking particularly at the third part of Jean-Paul Sartre's phenomenology of the body, the part that deals with our perception of our body as we perceive it through the way other people perceive it. So it's not our own experience of our body to experience firsthand. It's not objective knowledge of the body, the kind of things that we learn in an anatomy textbook, but it's the perception of our body as we come to see our body through the gaze of other people. Now, we can come back to that in questioning if you like. I have to say I'm not an expert in this field, but it does give us a very helpful way of understanding where Anna's values have come from. So in essence, we now have twin resources for working with values as part of shared decision-making in mental health care. Analytic philosophy, in the form of J.L. Austin's work, helps us to identify the values in the diagnosis of anorexia. Phenomenology has helped us to explain the origin of these values in the lived body for others, in Jean-Paul Sartre's terminology. And having understood the origin, as with other areas of medicine, we can then develop approaches to treatment. And that is what Giovanni Stangolini has been doing. And he's brought together those approaches to treatment in this book, The Therapeutic Interview in Mental Health. I'm sorry it's not a very good copy of the cover, but Bulent, you kindly mentioned the Values-Based Medicine series from Cambridge University Press, and this is a book in that series. As you can see, its subtitle is A Values-Based and Person-Centered Approach to Mental Health Care. So let me draw some conclusions and point to some resources for further study. We've gone through a lot of ground, and thank you for your sustained attention here. We started with a general introduction to values-based clinical care. Key points: values are individually diverse, covering anything that matters or is important to the person concerned. Values-based practice offers us a process for balanced decision-making on values. Like evidence-based practice, values-based practice is a process, and these two processes come together as partners in shared clinical decision-making. And that has been recognized, at least in the UK, as the basis of person-centered care by developments in medical law. Remember our Supreme Court Montgomery judgment, and in professional guidance, the GMC's consent, patients and doctors making decisions together. I then illustrated that with Mrs. Jones's knee. And the bottom line was that everybody wins. It was a better patient experience. We saved a lot of money for the health service, and the clinical team were very pleased with the clinical outcome. And it's stories like Mrs. Jones that have made shared clinical decision-making the basis of best practice in person-centered care. But when we came to mental health, we found that the same approach, and in principle, the same approach should be adopted in mental health. Psychiatric guidance in the UK requires this. It's the same model, but it's considerably more challenging, more difficult. And I've looked today at the way it's more difficult through the values base of shared decision-making. I think it would be fair to say that our evidence base is also often more difficult, but certainly the values base is more difficult. And we looked at that through Anna's story, and that took us to the need for moving from analytic philosophy as a way of identifying values to phenomenology as a way of understanding their origins, and then, as in Giovanni Stangolini's work, building therapeutic models. So we have twin resources, the analytic philosophy and the phenomenology, in turn leading to treatment. If you want to look further into any of this, here is the website again. And the website covers values-based practice, the way we can work on values in practice. It also covers the theory, the kind of theory that I've been talking about. Here's a few examples. If you look particularly in the section more about values, more about VBP in the website, you'll find reading guides to the theory and practice of the approach, a glossary of terms, full text downloads, and that now includes one of the books you kindly mentioned, Bulent, the Oxford textbook of philosophy and psychiatry. Oxford, rather to their surprise, and certainly to my surprise, made a lot of money out of the Oxford textbook. We rather expected it to be a lost leader, as they say, but they did make a lot of money. And they've now kindly agreed that we can make the textbook available open access. And that is available now as an open access resource through the Values-Based Practice website and also through its sister website, the website for the International Network for Philosophy and Psychiatry, the INPP. And then finally, we have this, what we've called the Wiki VBP library. And Wiki means that we depend for building that library on our colleagues submitting contributions. So we don't claim that it's comprehensive, but it has already a couple of hundred entries in it. And it's a library that focuses on resources for working with values. So it doesn't cover ethics, but it does cover all the different approaches to working with values in the way that I've described, understanding values in this broad sense of anything that matters or is important to the patient. So there's plenty about how to do values-based practice. There's also this book of case studies that you may find helpful. This is, again, one bullet that you kindly mentioned that I wrote with two colleagues, Ed Peel and his, in fact, daughter, Heidi Carroll. Ed and Heidi are both general practitioners writing this book, which is a set of case studies going across different areas of medicine. I have to say I learned more about medicine writing this book than I ever learned as a medical student. So it was a great experience writing this book with my two colleagues. And this is a French translation of the Essential Values-Based Practice, which was led on by our colleague Arnaud Pagnon. There is also a Japanese translation, which I haven't put up here. I can't speak to its validity because my Japanese is considerably less extensive than my French, but I can tell you that the French translation is very wonderful. And if you find French as your first language, this book is also available from Oxford University Press and through our French colleagues at Jean Liby Eurotext. Most recent development, which, Driss, I think comes back to your point about the importance of networking, and you cited Aristotle on human beings as social animals. We've realized, and I say this against myself, we've realized rather belatedly that the important values are often social and political, not individual and personal. And this book, which is a collection again of case studies, in this case, it's nearly 50 different case studies that were collected up by Drozdoj Stoyanov as the first editor there, together with our colleagues Giovanni again, Verdi van Staden from South Africa, Michael Wong from Hong Kong, and myself. And we simply went to our colleagues, networked with our colleagues and said, have you got any interesting cases? And we emailed, I think, nearly 50 colleagues thinking we might get 1 in 4 returns. They all sent us wonderful cases. So we ended up publishing the whole lot. And it's a thanks to our colleagues, it is a wonderful collection of cases of the way social values come into all areas of mental health policy and practice. And again, you'll see that's an open access publication with the link there that you could pick up through our website or from this PowerPoint. So I'd like to thank again Bulent and my colleague Driss. I'm afraid I've gone on slightly longer than you did, Driss, but I did warn you that that might happen. And thank you for your attention. And are there any questions?
Of course, there would be. Thank you very much indeed, especially the open access resources you have shared. I have seen one. And I was indeed surprised. It's an open access material. I would suggest my young colleagues and all those who would be watching this session. I have a few things to say, but before that, I would like to ask young friends if they would like to share their thoughts. Maybe we could start from Onur this time. Oh no, Irem this time. She was the last in the previous term. Please, what would you say, comment, or ask, Irem?
So firstly, thank you for your wonderful presentation and the links that you shared. So I'll ask again about medical students. I think that it's so important to look from patients' perspectives during our treatment procedures. But during medical school, we mostly learn how to perform evidence-based medicine. And I think that the philosophy and phenomenology behind the values-based medicine don't get enough importance during this period. So how can we integrate this values-based medicine in our medical courses? Should we add philosophy courses into our medical program, or how can we do? Thank you.
Thank you. It's a very shrewd question. Thank you very much. So my answer to you is I want to start by explaining how we've done this in Oxford. And you'll see this is for a reason. In Oxford, the medical students get their training in values-based practice when they're doing surgery, not when they're doing psychiatry. They do it in surgery. And that is partly historic because the co-director and now director of the centre in Oxford is my colleague Ashok Handa. And Ashok is tutor for surgery in Oxford, and therefore he has control of the surgical syllabus. So it was easy for him to introduce values-based practice in surgery. But the medical students really enjoy doing values-based practice in surgery because they see it as part of their everyday clinical work. And I think you're right. If we start talking about phenomenology and philosophy, then some of our students will be very interested, but many will not. And you don't need philosophy and phenomenology for most areas of shared decision-making. If you look on the website, another open access resource is a training manual, a self-training manual for values-based practice that I developed with a colleague from nursing care nearly 20 years ago now. It was one of the first training manuals. I did this when I was working for the Department of Health as a special advisor. And the training manual is very much based on methods that my colleague called Kim Woodbridge developed. And Kim happened to be very interested in philosophy. It was how I met her. But we didn't use the word philosophy in the whole training manual. We didn't need to, because it was the product that people were working with. So you don't need philosophy to do a lot of values-based practice, to do shared decision-making. You need good clinical skills. But if you're going into psychiatry, keep the philosophy and the phenomenology in your back pocket, ready to start training in, because I think you will find that it gives a wonderful depth dimension to the work you're doing in psychiatry. Now, I'd like to add a word of caution. I think, Driss, I imagine you would be encouraging to medical students and potential psychiatrists to think about reading in philosophy if that's their interest. But most of our colleagues would say, oh, a lot of rubbish. You don't need philosophy and phenomenology. And no, I think they would, Driss. I know WPA is different. The World Psychiatric Association was hugely supportive to this movement. The Royal College of Psychiatrists in London was hugely supportive. But don't be surprised if some of your teachers say you don't need philosophy. Remember, the teachers have not been taught philosophy. They think they can do without philosophy. They think they can do without phenomenology. And of course, you can do a lot of medicine without philosophy and phenomenology. In the really difficult parts of medicine, and that's where I see psychiatry, you do need these extra skills. or at least an openness to those extra skills. So we don't all need to be biochemists to be able to use the results of biochemistry, but we do need to be open to the results of biochemistry. It's exactly the same with philosophy and phenomenology. Some of us will get very interested in these areas. I'm now based in the Faculty of Philosophy in Oxford. I retired as a psychiatrist a few years ago, although I had worked clinically as a doctor for 50 years. So you don't need philosophy to do it, but if you want to do a really difficult and challenging area of medicine like psychiatry, keep it in your back pocket, ready to dip into when you need it. And there's lots of ways that you can engage with philosophy if you want to. I mentioned the International Network for Philosophy and Psychiatry. That's a very good international group that, and we have a new website. We've just renewed the website for that. And it's a good way, if you join up to the website, you'll then get notices about things happening in the field. So study the medicine, study surgery, and work really hard, as Dries said, to understand the best you can in your own field. And if you want to take on the challenges of working in a really difficult area like psychiatry, then be ready to learn a bit of philosophy and phenomenology as well. Okay.
Is it too late for us, dear Bill?
Never too late. If Dries is running marathons at the age of 72, we can all learn some philosophy and phenomenology.
Thank you. Thank you very much.
You know, Bill, sorry to interrupt. You know, I'm in fact, the longest distance I have run is 14 kilometers. And I'm extremely surprised. I never thought that it would be possible for a man of 72 to do that. I mean, I know some people do it.
Yeah.
But not for me, especially that I had a bad knee about 3 years ago. I had I fell, I had a lot of blood in my knee and could hardly walk.
Yeah.
But still that was progressively possible to train and to have more muscles and to have a better. No, it's really something important to know that mostly what we know is something that is surrounded by question marks all the way.
Yeah.
The certainties are terrible things. I mean, the most important thing is all the questions around the certainty. Now, in Casablanca University, I have taught medical students second year, every year for 25 years, human sciences. That is history of medicine, sociology, philosophy, psychology, medical psychology. And that, I mean, people remember that very, very, very strongly. It's the beginning of medical studies. And they keep it. I mean, some people I met recently, they are 62, 63, they still tell sentences I have given in the early 80s to them when they were medical students at the second year. And philosophy is very important, of course. I mean, we can't do without it. Just give you an example. I mean, one sentence, I mean, terrible sentence for some people. And I think it was quite Nietzsche saying man is just in the middle pillar of a bridge between the monkey and Superman or whatever. I mean, kind of. And when you hear that, you think of Nazis and people who would like to be the higher
super race
as compared to the others. No, it's not that. I mean, he just thought that if we came from apes, then probably we will move and change and we'll become something else different, maybe more powerful. And that's it. And when you think that, for example, somebody like Elon Musk, having put a number of electrodes in the brain and allowing people who are unable to walk again, or unable to do something and they think and they can open a door, they can, I mean, this is kind of Superman. This is a superpower that can be helpful, but can be also destructive. I mean, there is no power that cannot be both positive and negative effects. So,
I'm grateful to you for your advocacy for philosophy, but I do feel it's important that our young colleagues recognize that you and I might have a much more positive idea of the importance of philosophy than many of our colleagues. And, if you want to progress, I'm afraid a very practical issue about progressing in medicine is don't upset your professor. And if your professor's not keen on philosophy, don't push it. But there's plenty of places where you can get lots of philosophy. I think, Dris, your students must be very fortunate in having your wonderful teaching of the human sciences, which, as you say, is really as much philosophy as science. And that's how it should be. I would say that, I said that psychiatry is a challenging and difficult area. It certainly is. And it's very challenging clinically, it's very challenging scientifically, and it's very challenging philosophically. And I would like to mention the way this works in Oxford is that although, in the philosophy faculty, we have 60 full-time members. And a few years ago, we did a survey to find out what everybody's interests were. And out of those 60 members, we had 20 who described themselves as generalists. They were interested in different areas of philosophy. We had 20 who described themselves as being interested in philosophy and the cognitive neurosciences, psychiatry and the cognitive neurosciences. And then there were 20 who described themselves as being interested in a different area of science altogether. Could anybody guess what that area of science is? Bulent or Dris, have you heard this story before?
No.
So we had 20 who said they were interested in philosophy and quantum mechanics. Now, I tell that story because I think we need to understand that psychiatry is difficult in the way that quantum mechanics is difficult. Quantum mechanics is a very advanced science, and that's where we are with the brain sciences and psychiatry. It's a very advanced area of science. And the reason that we need philosophy and psychiatry in a way that, if Ashok, my colleague, will forgive me, they don't particularly need philosophy in surgery. And the reason is because the science that we work with is so very much more advanced. Dris, you talked about inserting electrodes in the brain. Well, brain scanning is something that even when I was a medical student would have been seen as a miracle. And the science is extraordinary and very advanced. We have in St. Catherine's College a fellowship for philosophy and psychiatry. It's an endowed fellowship. It has £2 million of funding behind it. It's not me who holds that fellowship. It's a young man called Philip Corrales, who's a German philosopher who trained in the States and in the UK. And Philip Corrales is working in semantic logic, right at the very cutting edge of the cognitive neurosciences. And that's what we need to understand. Psychiatry is not a sort of poor relation of surgery. Psychiatry is where the most challenging science is taking place, the most challenging clinical work. And that's why we need philosophy as well as science. And Dris, I think you're a wonderful example of one of the few people I know in the world who can convey both the science and the humanism and the philosophy in one person.
May I, at this point, turn our attention to Onur, who is also dealing with neuroscience as well. And I have seen from his eyes that he was very interested in what you tell. And before going to Onur, I would like to say one thing about Dris. I think his motivation is related with his values, because he still can run 12 kilometers even if he had a bad accident. I mean, you both have links among what you have shared with us. Yes, now let me turn to Onur, taking into consideration the limited time we have. Please, Onur, may we listen to you, your comments.
Well, philosophy and psychiatry are actually like the areas that I'm most interested in, because even when I was in high school, I actually worked with Turkish Philosophy Association. So I like it a lot. And when I started out my PhD, I wanted to do actually neuroscience of aesthetics. So, I mean, watching this presentation on ethics kind of was like very fun. And I would really like that. I mean, I would really wish that this was a more common thing among our like older teachers, more focus on values and not just ethics, but in values in general. That's I just want to say that.
Yeah.
Thank you. We shouldn't forget that you will be the teachers in the coming future. So with this vision, I'm sure you will bring in, and especially having different information or different vision from different parts, you will be able to bring them together. Yes, Pelin, before we come
could I just respond to
please do so.
One of the people you might want to explore in Oxford is Julian Savulescu, Savulescu. Julian has a department, a whole center called the Center for Practical Ethics, and it's the UEHIRO, UEHIRO, the UEHIRO Center, UEHIRO, and they do a lot of work between philosophy, ethics, and neuroscience. So have a look at his center. Thank you
so much.
If I may, I would like to add one thing. Ethics has been and still is an essential part of philosophy. And there is no medicine, valid medicine, without ethics. So as simple as that. I mean, how can you say that in medicine you can forget about philosophy? While ethics is the mother of all practice. I mean, if I may say so. I mean,
well, Dries, that is very fair. And again, you are advocating for my own field, so thank you. But I remain, from my experience, I do want our colleagues to understand that not everybody shares our, dare I say, enlightened view, and that if their own professors are not open to this approach, my experience is don't push. I think you gave us very wise advice, Dries. You said find the people who have the same interests as you and understand your interests. It's really important to find the professors who will relate to your interests. I think we all need professors who are critical. Dries, I'm sure you remember the professor in Oxford. I'm blocking his name for the moment, but you know who I mean. Do you remember his name?
The Oxford Textbook of Psychiatry?
Yes.
Yes, of course.
Yes. Anyway, I'll remember his name in a moment. But basically, he was very supportive to me when I said I wanted to do a PhD in philosophy.
He was a good man.
But he said, this was 30, 40 years ago, he said, Bill, I will support you to do this because I think you have good ideas, but you must understand I am responsible for your career as your professor, and you're making completely the wrong move. So he and he supported me very strongly, but at the same time kept warning me that it was a dangerous route to go in psychiatry. And of course, he was quite right. And then when we started all this new work going and philosophy of psychiatry started taking off, of course, he was a great supporter. Michael Gelder was his name. Gelder.
Michael Gelder. Yes. I was trying to find out this.
Yes.
His name.
Well, I got there first. You see. But Michael Gelder was the perfect professor because he was very supportive and he protected me in very difficult situations in Oxford, but at the same time was very critical. And it meant that we had to work really hard, as you said, Dris, very hard work to produce work that was of a good standard. And I think but you do need people who you do need professors and senior people who basically believe in what you're trying to do. And that is very important. And I do completely agree with Dris about that.
And I would like to add, if you do not have professors who would understand your interest, be patient and wait until you are the professor.
Yes.
May I ask Pelin what she has to say? It's so nice to be together with both of you and the young colleagues, but time, I have the pressure of that time. Please, Pelin, what would you like to say?
At first, I would like to thank Professor Filford for your great presentation. You mentioned two examples in your presentation. One was related to the surgical field and the other one was about mental health. I understand that the use of values-based practice is more difficult when it comes to the mental health. In psychiatry, although diagnostic criteria are used, sometimes it is even difficult for different psychiatrists to make same diagnosis or to have same approach for the same patient. Considering this, what can you say about values-based practice for psychiatric conditions like mania of bipolar disorder or a psychotic episode?
Thank you. Again, a very good question. Anything that is difficult in non-psychotic conditions becomes even more difficult with psychotic conditions. In the early days of values-based practice, one of my philosophical colleagues actually worked with a colleague of Julian Savulescu, the person I mentioned earlier, on mild mania. And what he pointed out was that once you understand the way people's values change when they go through a manic episode, it then becomes very difficult to say what is the well person and what is the ill person. And it's the values that are driving that. I don't have a quick answer to your point, except that it highlights the importance of recognizing these conflicting values and developing ways of working with them. I'd like to extend my answer very slightly, if I may, Bulent. I know we need to finish soon, but an area where your question is particularly pertinent at the moment is in the area of race equality and mental health. Now, in the UK, and I believe this is similar in some other countries, we have a particular problem because involuntary treatment, compulsory treatment in psychiatry, which is always contentious, of course, where the patient is treated against their wishes, this happens when people are psychotic. There are good reasons why sometimes when people are psychotic, we need to treat them, even though they're saying their values are that they don't want to be treated. The problem is that in the UK, if you are a young Black man, so from Africa or the Caribbean, you are many times more likely to be treated on a compulsory basis than if you're a young white man with the same condition. Now, there are different theories of why that is the case, but the view that we have in the center is that, and we're working with Dr. Colin King, who's a person who is a Black man, has been through this experience. The view we have is that it's not that the condition of the patient is different, it is that the condition is viewed differently if you're a Black man than if you're a white man. Now, this is very contentious, and the Royal College of Psychiatrists wouldn't necessarily agree with us about this, but that is our informed view, that this is a very good example of where failing to look at the values that influence the way we make diagnoses, failing to look at the values can lead to a result that is, in most other terms, bad for the patient. I did some one of the reasons we believe this is because I did some work 20 or 30 years ago with a Russian psychiatrist about the state of Soviet psychiatry in the 1960s, late 1960s and 1970s. And this was a period when in Soviet psychiatry, people who were dissident, people who disagreed with the Soviet state, were often being diagnosed with schizophrenia and sent to psychiatric hospitals instead of being arrested and sent to a prison camp. Now, at the time, Western psychiatry thought this was because Soviet psychiatry wasn't doing good science. I looked at the Russian literature. I don't speak Russian, but my Russian colleague, of course, was his first language. And he had a year in Oxford, and we got the Russian literature out and analyzed the way they were understanding schizophrenia in Russia and compared it with the way we were understanding schizophrenia at the time in Britain and America. And they were identical. So it couldn't be that there was bad science going on to explain the overuse of a diagnosis of schizophrenia in Soviet psychiatry. We speculated that it was a different set of values. So in Soviet psychiatry at the time, to put it crudely, you have to be mad to disagree with the state. That was the Soviet value. And we believe it was that was driving the abuse of psychiatry in the Soviet Union. There were other factors, but that was at the heart of it. I mean, I think we're now seeing a similar thing, at least in British psychiatry, with the overuse of psychiatric diagnoses in young Black men. I think that they are being seen as mad in a way that young white men are not. And we need to recognize that and recognize that it's not that we're deliberately wanting to treat people badly. It's because we don't recognize how our values are influencing the diagnoses that we're making. So your question about psychosis is a very important one. And that's one example of where that importance plays through into the practice of the field. Thank you.
You are telling us very interesting things and challenging views. Really, what we have been told in the history of recent period. We have some questions coming, especially the situation in these hard days. But due to time restriction, I would like to announce one thing and try to come to a concluding this session. We had private discussion with Professor Fulford, and he agreed that he might share with us his special exercises in a certain area. I mean, if we have some interested people, he will be using with us, he will be sharing with us his exercises, and he will be having some discussions with young people. So I haven't been able to explain it properly. Would you, as a last word of yours, could you open that a bit and let's propose it for near future?
Well, it's very kind of you, Bulent. I suspect everybody will have heard enough of me, but if they did want to try out some of the training exercises that we do with our medical students in Oxford, we are developing an online version of the training. It has to be interactive, and it does require our students to do a little bit of work on the exercises, but it's a way of experiencing values-based practice and learning and developing your own skills at the same time. It's what we do as a collaborating center. So if you did want to arrange a session in the future and you had a group of colleagues who would be interested, we'd be delighted to liaise with you. It would either be myself doing it, or it might be myself with Ashok, the co-director, but we would be delighted to work with some of you on this. I think you would need to set aside probably between an hour and a half, or maybe 2 hours, and we would do some exercises, look at some cases, and discuss the way it works in a bit more detail.
For such a special session, we could spare maybe more than 2 hours.
I think 2 hours would be plenty.
And fine. Because I personally had a lot of questions to ask to both of you, but I have to stop myself. And maybe we would need another session for such discussions. Before finalizing, ending, I would like to ask his last words, if I may, to Dris. Would you like to say to finish our meeting?
Maybe just one thing. I mean, you will learn a lot of certainties in medicine. For example, when I started medicine, it was very clear that the ulcus, gastric ulcus, was due to too much acid in the stomach, and this is how it put holes, and sometimes it became cancerous and so on. After that, they understood that it was a bacteria, I mean, Helicobacter, that is responsible of that, and you give. So when I was medical student, it was first too much acid, second surgery that cuts 2/3 of the stomach and throw it away instead of giving an antibiotic. So all certainties you have today might be completely changed. So whenever you have a certainty, put question marks around and try to find out. And this is philosophy, in fact. Philosophy is just asking questions about certainties.
And especially in the hard days we are going through, we have to ask many questions. Dear young friends, dear distinguished colleagues, thank you very much for being with us. Hope to be with you in the future.
Thank you very much for inviting us, Bulent. Been a wonderful session, and very good to see you again, Dris.
Yes, same for me.
Bye-bye.
All the best.
Bye-bye.